Hello, this is Dr. Neal Jackson. This discussion is on cochlear implants with information for general audiences. So here are some highlights about cochlear implants. Cochlear implants are medical devices for people with severe to profound hearing loss or deafness. They are eligible for patients of all ages, so from babies who are born deaf to the elderly people who have lost their hearing for various medical causes. Cochlear implants work differently than hearing aids. In fact, there are two parts of a cochlear implant system. One part is the internal part. This is what electrically stimulates the inner ear, where the nerve of hearing is. This electrode is placed during surgery and is considered somewhat permanent because it's inside the body. This is seen here on the cartoon of the ear. The patient also will receive an external component, which is worn outside the body. This is worn really behind the ear. This has a microphone, a speech processor, and can be upgraded over time. The patient is able to freely remove the external portion whenever they wish to do so. Surgery for the implant takes about 1 to 2 hours. The patient is totally asleep in the operating room, and they can go home the same day. Overall, the surgery is very safe. It has a very low complication rate of around 1%. What happens is after the surgery, the patient goes home. They come back to the clinic around 2 to 3 weeks later, and then they get activated with their implant, and they begin to hear with the implant. And then the patient should expect gradual improvement over months, if not years. Hearing with an implant is different compared to natural hearing, and the hearing is not perfect. But for those patients with severe hearing loss who get implants, the vast majority of them can begin to understand oral communication again. So this means that for a child in school, they can understand their teachers and their peers, and for adults, they can once again socialize with their friends and family. As the technology continues to improve in general, that technology gets incorporated into the cochlear implants, and over time, we've seen more and more improvements. Okay, so those are some of the highlights. These are some common questions that I get usually in follow-up for that. So again, people want to know, what is a cochlear implant and how does it work? We'll talk about how there are the two parts of the system. There's one on the outside, which is the sound detector and the sound translator from the sound waves to a digital signal. Then the internal part is what actually goes into the cochlea and stimulates that hearing nerve directly. Who should get a cochlear implant? Well, it's really for people that have fairly bad hearing where hearing aids are not very beneficial or sometimes not beneficial at all. As far as the age, the youngest age is maybe 6 to 9 months. That age has kind of gone down over time. It used to be 12 months, now it's 9 months, and even for some manufacturers, we're doing as young as 6 months. What age is too old? There's really not an age limit. I've done people in their 90s, so there's not a medical reason that a patient is too old for a cochlear implant. As far as the testing that's done to determine who gets an implant, it depends on the patient. So if it's an adult, we'll test them with their hearing aids in, and we'll see how they can hear and respond to sounds, specifically speech sounds and sentences. And for a baby who can't communicate like that, we'll do some physiologic testing where the child may be sedated, and we'll place some sounds into their ear. We can track the nerve signal from the cochlea to the nerve and to the brain and get a pretty good idea of how their hearing is. Another question is, why not just stick with the hearing aid? Why do this cochlear implant and why go through a surgery and all that kind of stuff? Well, a hearing aid and a cochlear implant are different. They're both medical devices that help you hear, but a hearing aid is really just an amplifier. So it can make the sound waves stronger, but it can't change things in the cochlea necessarily. A cochlear implant goes into the cochlea and stimulates the hearing nerve directly. So that is a big difference between a cochlear implant and a hearing aid. As far as the timing of an implant, what about a baby who's born deaf or hard of hearing? We mentioned earlier that we can implant them at an age of like 6 to 9 months or 12 months. But maybe can we just wait a few years and just see how they do? Why rush into surgery on a newborn? And the reason is that young age is a very critical time of hearing in that child's life. And so if we delay their hearing, we can really delay their speech and their language development, which can impact their learning and their social skills as well. Another frequent question we get is, why is there something on the outside if this is an implant? And the question goes back to the part that there's two parts to the cochlear implant system. So the part on the outside, the external part, must be worn to give the sound signal to the internal portion of the implant. Another question is, great, I'm getting the latest and greatest cochlear implant in the world. Can I expect the hearing now to be perfect with a cochlear implant? And the answer is no. The hearing will still not be perfect. But for many patients, the hearing with the implant is better than what they can do with their hearing aids, and that's why we recommend it for those patients. And finally, what happens in the future as new technology develops? The short answer is that the external component can be upgraded over time. The internal pretty much stays in, I'll say forever, or at least for a few decades. And I don't know what's going to happen in the future. But for the most part, we are incorporating new technology mostly into the externals. So the reasons to consider cochlear implants are if you have a hearing loss at what is considered a moderate to severe or profound, that is deaf, levels, or if you wear hearing aids and really there's limited benefit or perhaps no benefit from wearing the hearing aids. The most common medical reasons to get a cochlear implant are hearing loss over many years, which we call presbycusis, or a child who is born deaf. This is considered a congenital hearing loss. Then there are also other things like hearing loss that can occur all of a sudden, which we call sudden hearing loss, single-sided deafness after having meningitis, which is an infection of the lining around the brain, with chronic Meniere's disease, and even more causes. So I am Dr. Neal Jackson. I'm a pediatric and adult neurotologist, otherwise known as a ear and skull-based surgeon. I have the ranking of associate professor in the departments of otolaryngology and neurosurgery. And I am a pediatric and adult ear surgeon. And so what that means is that I have done thousands of ear surgeries in my career, including hundreds of cochlear implants. I have been the director of multiple cochlear implant programs, and I've implanted patients as young as 9 months of age and as old as 90 years of age. So in this discussion, I would like to talk about how implants work, who is eligible to receive them, how the surgery works, the external component, and of course, some realistic expectations. One important disclaimer is that this is not medical advice. This is really just for informational purposes only for general audiences. For medical advice, of course, you should seek care from your doctor based on your unique situation. And also, this is fairly general information. This is not going to be comprehensive, and so this may not apply to all people and all different clinical situations. So just a brief review of the anatomy or the structure of the ear. So there is the external ear, which is lined by skin. There's the ear canal, which leads down to the eardrum. The eardrum is partially cut away here, so we can see the 3 bones of hearing, the malleus, incus, and stapes, also known as the hammer bone, anvil bone, and the stirrup bone. And then after that, the sounds will then travel into the cochlea, which is a spiral-shaped organ. It has about 2.5 turns in the spiral. And after that is where the nerve, seen as yellow here, the nerve comes in from the brain to hear the sounds that the cochlea produces. So if you want to learn more about hearing, here's an explanation. So if you can imagine that all these blue circles are sound waves entering into the ear, these are all sorts of sounds entering in. These are low-frequency sounds, high-frequency sounds. They travel through the ear canal to the eardrum, and this sets the eardrum to vibrate. As it does so, the eardrum will then contact the first bone, the malleus, the second bone, the incus, and the third bone, the stapes, and they will also move in unison as well. So far this is all mechanical sound waves coming in. Then what happens is those mechanical sound waves get pushed into the cochlea, again, which has about 2.5 turns usually. And this is where those mechanical sound waves get converted into an electrical signal in the natural hearing ear. So you can imagine all these little yellow dots are electrical impulses or action potentials firing off inside the cochlea. The nerve inside the cochlea can then sense these and carry these sensory sensations deeper into the ear and into the brain. We now know that different portions of the cochlea can detect different sound frequencies. So for example, in the beginning part of the basal turn of the cochlea is where we hear our high frequency sounds. And in the apex part, the middle part, that's where we hear our low frequency sounds. This is very important because When we place a cochlear implant into the cochlea and we're going to try to recreate sound, we want to stimulate those nerves endings in the proper spots to re-simulate or recreate the sounds that are heard in the environment. The problem with many patients who get cochlear implants is that this process does not work properly. This really happens at the level of the cells. So in the normal hearing ear, as those sound waves come in, basically they are sensed, and this causes these little cells to be deflected or sort of pushed over, and that causes enough of a mechanical change for the electrical change to happen. The problem in patients who get cochlear implants is that that process does not work properly. And therefore, even though the sounds come in and the eardrum and the bones of hearing do their job, no nerve signal is created to be passed on to the brain. So in the ear, we can basically divide the outside portion, which has the ear canal and the eardrum of the bones of hearing. This is where a conductive hearing loss would occur. And then inside of that, much deeper into the ear, and really as part of the skull bone, is where causes of sensorineural hearing loss can happen. So things like a middle ear fluid, like otitis media, a hole in the eardrum, these are all going to be external things that cause conductive hearing loss. And then things like cochlear cell loss, cochlear cell dysfunction, cochlear malformations, post-meningitis, things like that, those are going to happen inside the cochlea and cause sensorineural hearing loss. As far as how we manage sensorineural hearing loss, really one must understand that we can measure hearing in different levels. And so if the patient can hear sounds at a very quiet level, we say that they have normal hearing. But if the sounds must be played louder for the patient to be aware of them, we can then grade the hearing based on how bad the hearing is. So for patients who have mild hearing loss, who can hear sounds at a decibel level of 20 to 40 decibels, most patients can get by with this, or if they need something, maybe they might consider a hearing aid. Same thing for a moderate hearing loss in this range. Most people can get by with a hearing aid. But once we get beyond this level to either the moderately severe or the severe or the profound hearing loss levels, this is really where the cochlear implant really kind of has a role to play. This is different than in the past when a patient had to be basically off the chart deaf to get a cochlear implant. Nowadays, a patient can still have some residual hearing in this range and still be a candidate for a cochlear implant. Cochlear implants are for patients with moderate to profound levels of hearing loss. And what does that mean? That means that the sounds must be played much louder for them to even be aware of them, to detect them, or that the sounds are not clear. And this is really important, especially for speech, because if you're aware of a sound but it's not clear what it is, you're really not hearing very well at all. Symptoms of patients who receive cochlear implants are typically the following. The most common thing is that patients will say something like, "I can hear, but I don't understand what you're saying." And what that means is that their ear works somewhat. They're able to detect some of the sounds, but they're not able to do it very well where they can actually understand speech. And so they have a partial hearing loss, which really impacts their ability to communicate. So they have difficulty understanding speech. They'll have difficulty with conversations in noisy environments. They may have difficulty talking on the telephone or in the car where there's background noise and they may not be able to see the person that they're talking to. And really, many of them, they have what we call limited benefit from their hearing aids. So even though they wear hearing aids, the hearing aids aren't doing enough to satisfy their hearing. So, cochlear implants versus hearing aids. Cochlear implants work differently than hearing aids. They both use microphones and digital processors to analyze sounds and help you hear better, but a hearing aid basically sits on the outside in the ear canal and will amplify the sound waves. It'll try to send them through the ear at a stronger level, basically. But if the problem is still that the cochlea can't convert those sound signals to a nerve signal, then a hearing aid is not going to help very much. A cochlear implant works by directly stimulating the hearing nerve itself, by going directly into the cochlea. The cochlea itself is very fascinating to me. I think it's very unique, it's very interesting. As we discussed earlier, it's the only part of the body that can convert a sound wave to a neural or a nerve signal. Each cochlea actually will talk to both sides of the brain, which is a unique thing in our body. The cochlea is functional before birth, meaning babies are hearing in the womb before they're born. And also the cochlea is full size before we're born. The cochlea begins developing pretty early in our life in the womb, and it is full size before we're born. And really one could think about it as these soft functional parts, those little bitty cells that I showed you in the illustration earlier, that are inside this hard bony shell or bony covering. And so even if there is some damage to the inside of those soft functional parts, the hard shell is still there. And that allows us to use things like cochlear implants on the inside. Another fascinating thing with the cochlea, as discussed earlier, is what's called a tonotopic organization. What that means is that we hear different sound frequencies in different portions of the cochlea. So this is a little bit different in each person, but in general, we hear the high frequency sounds in the first part of the cochlea, seen here in purple. And as we go deeper and deeper and take about 2.5 turns, we hear the lower and lower, or like the bass pitch tones. This is sort of a view from the top, is sort of a view from the side, showing the unique shape and structure of the cochlea. This is really important because if we're going to do a cochlear implant, we want to know what we're stimulating. So here's an illustration of an implant sliding into the cochlea. And each of these little segments here is a stimulating electrode. And so we want those electrodes to stimulate at the right areas of the cochlea. So when we want to recreate the bass tones, we want them to be stimulating all the way in the deep part of the cochlea. And when we stimulate the high frequency tones, we want them to be in this first part of the basal turn of the cochlea. We can even measure how deep we insert the electrode based on an angular insertion depth, and that'll help us program the implant correctly. So implants, how do they work? I really think about the cochlear implant being a cochlear implant system, because there is the external sound processor as well as the internal implant. The external portion is seen here in the cartoon, has the computer and the processor in it. And then the internal portion seen here in the cartoon is the part that actually goes in and stimulates the inside of the cochlea. When a patient wears it, it's visible externally. This is a portion that can be removed whenever the patient wants to. On the inside is the silver part here, which is part of the internal electrode. Here's a closer up view of the internal device. This portion is called the receiver stimulator. It sort of receives some input from the external portion. This part is then the stimulator, and this little part right here is what actually goes into the cochlea. This is called the electrode array, and this is very, very small. If one looks at it very closely, they'll see that the very tip of this is less than 1 millimeter. It's usually 0.5 millimeters or less. Electrodes are also very flat nowadays, and this has been beneficial for patients because we can make smaller incisions and do smaller surgeries to slide in a smaller implant. The internal device, as I mentioned, this sort of is the body of the implant, and then the very tip of it with the array is very soft, very flexible, very small. Sometimes we surgeons will say that this is similar to a cooked piece of angel hair pasta. It's very soft, it's very flexible, and we want to be very, very careful whenever we place it inside the cochlea. It's important to know that there are 3 manufacturers currently for cochlear implants that are on the market. I use all 3 in my practice. There are different device options within each manufacturer. That's a discussion that you can have with the surgeon and with the audiologist about which one might be best for you. The external component, again, this is where all the software is. This is where the brains of the implant are. There's a magnet in this and also a magnet in the internal component, and that's how the two stay together. The external part can be easily removed. Basically just separate the two magnets by pulling it away, and then it's off the ear. And also this is what's upgradable over time. So usually every few years a new one will come out and the patient can get an upgrade. All right, so let's talk about how the surgery actually works. The surgery has a few key steps. They include making an incision behind the ear and then placing the receiver stimulator under the scalp, as seen here. Next, we'll pass the wire with the electrode through the mastoid bone, through a small area bone called the facial recess, then finally into a very small target around 1 millimeter in size, which is our entrance into the cochlea. This allows the electrode array to pass all the way into the cochlea and then spiral around into the natural shape of the cochlea. The surgery itself takes about 1 to 2 hours. The complication rate is low, or around 1%. And there's really not much to do for the patient afterwards. Wound care is pretty minimal. I just ask my patients to keep it dry for about 3 days. All the stitches that I use will dissolve, and largely the outcomes are very successful. So the way that we would do this, so if we're going to do a patient's left ear, we turn the patient's head slightly away. We mark out an incision behind the ear, mark out where we think the receiver stimulator is going to live afterwards. We'll then make a skin incision and we'll cut through the skin and as well as the soft tissue between the behind the ear and on top of the bone. This is known as the periosteum. We'll then lift this up and we'll create a little pocket to house or to host the internal component. This is where the receiver stimulator will sit. So again, this is sort of above and behind the ear. Then we'll also drill the mastoid bone. The mastoid bone is the bone behind the ear. So in a cartoon fashion, this is what it looks like. This is the ear canal right here. This would be the front toward the nose. This would be the back of the head. So we drill through this bone called a mastoidectomy, and we are able to access these different areas. This is a view seen in the operating room. One of the areas I mentioned earlier that we have to pass the electrode through is something called the facial recess. So we drill open some of this bone here, called the facial recess. This is only about maybe 2 millimeters wide, sometimes less than 2 millimeters wide. And we're trying to get access to this, which is the round window, which is an area of the cochlea that allows us to insert the electrode. This is the facial nerve, the nerve that helps one move the face. And this is the nerve called the chorda tympani nerve, which is one of the taste nerves. So as you can see, we do have to go right by both of these nerves to put in the electrode. So those nerves are at risk during the surgery. Again, the complication rate of this is pretty low, around 1%, but they are risks. What we're aiming for, as I mentioned, is the round window. So in the operating room, this is what it would look like. We've got the mastoid bone drilled out, and then far in the depths, we have opened up the round window, which is only about 1 millimeter wide, as our opening into the cochlea. Here's an endoscopic video inside the ear. We've drilled open the mastoid, we've drilled open the facial recess, and right here, this dark little circular area, that's the round window that we're going to place the electrode through. Around this, we have the bones of hearing, the incus, and the stapes. And in a second, I can touch the incus. We can see the stapes bone move as well. These are our standard landmarks for cochlear implant surgery. And again, we're going to place the electrode right through this round window into the cochlea. As we do so, we introduce it, and the implant electrode should spiral around. So we'll introduce it in, and then it'll spiral around like this. It goes about 1 turn. It does not go the full 2.5 turns. So to recap, we make an incision behind the ear. We create a small pocket behind the ear under the scalp to put in the receiver stimulator. We drill the mastoid bone, known as a mastoidectomy procedure. We then open up the facial recess, which is about 2 millimeters wide. We then open up the cochlea through the round window, which is around 1 millimeter wide. and then place this electrode tip, which is about 0.5 millimeters wide, into the cochlea with minimal trauma. If you put it all together, this is what it looks like. So this is a cochlear implant surgery that I performed myself. So this is a left ear. I've marked out the incision. I've marked out hash marks that allow me to reposition the ear properly at the end of the case. So we're making our skin incision, and then we're lifting some of the soft tissue forward. Now we're placing a retractor to hold the ear forward during the surgery. And then we're cutting into the tissue called the periosteum. This is the soft tissue right on top of the bone of the mastoid. So we cut through this, we open it up, we're able to lift that soft tissue, that periosteum up. Now we're right on top of the mastoid bone. And then in a second, we're going to begin to drill some of the mastoid bone open. The mastoid bone is sort of like a sinus. It's like an open space. So there's nothing really inside of it that can be damaged. There are things around it to be aware of, such as the nerves and the brain, but there's nothing really within the mastoid bone space. It's really a bunch of what we call like air cells, like a honeycomb of air cells. So as you can see, we're going through this area. This does not cause any pain to the patient or any problems to the patient. There's no sensory nerves in that bone. As we drill deeper in, we'll kind of zoom in a little bit more, magnify our view. We'll start to see some of our surgical landmarks, such as the inner ear. And in a second, we'll see that incus bone that I mentioned earlier. So just drill a little more, and then now we can see the incus bone off here in the distance. There it is. And then I like to check the facial nerve. I mentioned earlier that the facial nerve is always at risk during the surgery. So I will check the nerve as many times as I want to during the surgery to confirm that it is working. And that nerve monitor helps me keep the nerve safe during the surgery. Next, we're drilling the facial recess. Again, this is that area that's around maybe 2 millimeters wide. This is an avenue we take to get into the cochlea. So we've switched to an even smaller drill bit here, an even softer one that's diamond coated. And so we're opening up more and more of the kind of air cells here in the facial recess. And in a second, after we've gotten through this bone, we'll have a good look at the round window. And so there it is, we're starting to see it. So now we've opened it up. We've opened up the round window. This is about 1 millimeter wide in diameter. And we're gonna make sure this is wide enough and open to accept our implant. And once we've confirmed it's open enough, then we'll take the implant onto the field and we'll actually put it inside the ear. So as I mentioned earlier, we create a pocket behind the ear. So I've already created that pocket, but for the sake of this video, I'm not showing that portion, but the pocket's been created. This is the actual cochlear implant. We're tucking it in the pocket under the scalp. As you can see, it slides in pretty easily into that pocket. And then the wires coming off of this, the main one of these, the long one, is going to be the one that goes into the cochlea. So we've taken it out of its protective sheath. This is the electrode array. We're placing it into the cochlea. We do this very carefully, usually over about 1 to 2 minutes. And we want to be very, very gentle. We want to minimize any trauma to the inside of the cochlea. So we'll insert this very, very gently, take our time. And oftentimes we'll get some live feedback from a sensor we can place that will connect to the implant itself. Then I'll basically pack off the implant, make sure everything is in a good stable position, and then we'll just close up the wound. So we close up the wound in layers of stitches. So I mentioned earlier how we lift the periosteal layer and lift it forward. Now we're closing that periosteal layer right over the implant itself. All these stitches are deep, these all dissolve. As you can see, we have the implant pretty well covered up again with the periosteal layer. Then we just close the skin. Again, this is done in different layers of sutures or different layers of stitches. I use those little guidelines to make sure that I put the ear back in the same position that it was before the surgery. And once I know everything is lined up, we'll place some more stitches. We'll make sure everything looks good, make sure everything is nice and watertight. Then finally, we'll do this last layer of stitches on the skin to make sure the skin is completely closed. After that, I will often add a little bit of surgical skin glue to help confirm that the wound stays nice and clean as the patient goes home for healing. We're able to check the electrode by both using some of the physiologic testing that I mentioned during the surgery, and also we can do imaging such as X-ray or fluoroscopy or sometimes an intraoperative CT scan to check the position of the electrode. What that looks like on a plain X-ray would be if this is an X-ray of the skull. This patient has had bilateral implants, as we can see up here, but we're looking here to see if we can find their electrodes, and as we can see, this is the electrode coming in. Here's the array with all those small contact points that are stimulating the cochlea on this side, and also this one also on this side. So this is an example of an X-ray checking position of a cochlear implant. What happens after surgery? Well, the patient goes home the same day. That way they can go home, they can rest, they can recover, they can heal. They then return in around 2 to 3 weeks to receive their external component. We call that the initial activation, or day 1 of hearing with the implant. So that is initial activation, and after that, we can then program the device. And so the audiologist is the one who does this, and they will provide the patient with a map of their implant programming. And this can be modified based on the patient's feedback. Then typically they'll have some more personalized programming sessions, something like every, the first 1 month, and then every 3, 6, 12, 24, and 36 months after the surgery. So we've talked about who is eligible for a cochlear implant. There's a few more things we have to check prior to surgery. Some of the other eligibility requirements are that the patient must have a cochlea, and they must have a cochlear nerve. And that might sound a little surprising for me to say, but there are some patients who are born without a cochlea, and there are patients who are born without a cochlear nerve. So especially for a baby who's born deaf, we have to do imaging to confirm that they do have a cochlea and they do have a cochlear nerve prior to attempting a cochlear implant. And again, who would get cochlear implants? These are patients with hearing loss who really get either no benefit or limited benefit from wearing their hearing aids. And this could apply to somebody at any age. It could be a baby, it could be a young adult, it could be somebody in their Medicare age range. As far as performance and outcomes, what one should understand is that patients are still considered to be deaf or hard of hearing, but they can hear with their implants. And the hearing through an implant might sound different from normal hearing, but it does allow people to communicate fully with oral communication in person and over the phone. And for many patients, this is something that they can't do even with their hearing aids prior to getting cochlear implants. And for children, because a child learns so much about the world by listening, a cochlear implant can provide significant improvements in a child's ability to learn and to communicate and to socialize. It's impossible to predict or guarantee precisely how each individual will do with hearing, but in general, the vast majority of patients are successful users of their cochlear implants. Cochlear implant surgery commonly leads to the loss of all the remaining hearing in the ear, so it's very important that the patient understand that the implant is a different way to hear, and that for the most part it is replacing what's left of their natural hearing. So what should a patient expect? Well, again, for the most part, most patients do well, and this occurs gradually over time. The hearing improvement is not immediate. It often will take months, if not maybe up to a year or two, for the patient to hear better. The sound quality is going to be different, but still better than with hearing aids for most patients. The patient should expect to wear the external portion of their implant essentially all day. And as there are continued technology upgrades in the future, they should expect to get a new external processor in the future. I'll wrap up with just a little bit more information as far as satisfaction scores that different patients reported. So if you take patients who have bilateral hearing aids that are appropriately fitted for them, and then they get one cochlear implant and still keep their other hearing aid, this is a comparison of how they did with the two hearing aids and then with one hearing aid and one cochlear implant. So in general, in this study, patients with hearing aids, only around 9% said they were satisfied with their hearing. But after they got one cochlear implant, 95% reported that they were satisfied. As far as the ability to understand what's said on TV, it went from 13% to 76%. We're able to hear conversations in a small group from 8% to 79%, and so on and so forth. So I think this highlights two things. One is that implants really help patients quite a lot. And the other is that these numbers are not 100%. So cochlear implants do not fix everything for every patient. But for many patients, they're still the best option for them to optimize their hearing. All right, so to wrap up this discussion, again, a cochlear implant is a medical device for people with severe levels of hearing loss. This can range from moderate hearing loss, severe hearing loss, or even profound hearing loss, which is also known as deafness. The best thing for the patient to do is to get a really good hearing test by a trained audiologist to see if they might be a candidate for a cochlear implant. This can happen for patients at any age. So a baby can be born deaf, or a person can lose their hearing really at any age during life. And it's important to understand that the cochlear implant works differently than hearing aids. In fact, many patients who get cochlear implants have worn hearing aids, but they get to a point where they get limited benefit or perhaps no benefit from their hearing aids. And so when we test a patient to see if they would qualify and be eligible for a cochlear implant, for an adult, we test them with their hearing aids in to do a comparison. As we discussed, there's two parts of the cochlear implant system. There's the internal component, which is placed during surgery, which was shown in the video. This is the inside part, which is pretty permanent, lasting for usually decades at a minimum. And the external component is the part that can be upgraded every few years. This is the part that's worn on the outside, sort of above and behind the ear. This has the microphone and the processor, and this can be removed by the patient if they choose to. If they don't wear it, they don't hear through the implant, but when they do wear it, they can get much better results. The surgery itself takes about 1 to 2 hours. The patient is asleep in the operating room and they can go home the same day. And overall, it's a very safe procedure. We do this on babies less than 1 year of age, and there's a very low complication rate of around 1%. So about 99% of the time, the surgery goes very smoothly and there's no problems. The implant gets activated about 2 to 3 weeks later, and then the patient should expect that the hearing will be different, and they should expect gradual improvement over many months, if not even 1 to 2 years, to get the full benefit from the implant. It is not like flipping a switch and then all the hearing is back again. It's very much a gradual improvement as the patient's brain learns to hear through the implant system. The hearing is different with a cochlear implant, and the hearing is not perfect. But for those who do receive implants because their hearing is so bad, the vast majority of them can understand oral language again. So this allows, a child in school to learn from their teachers and from their peers. This allows people to socialize. It allows people to talk on the phone and really connect with others, and sometimes in a very, very meaningful way. For some patients, the best option is a hearing aid, but for the patients that we discussed with severe hearing loss, the cochlear implant is their best hearing option. So thank you very much for listening to this talk. I hope you learned something.